Thank you. Thank you, Mary Claire. Thank you, Home Instead, for this opportunity. Over lunch break, I was introduced to Paul Ennis. Paul, if you could stand up, please. He works with Green Market Exchange, and for individuals that, perhaps he stepped out, but for individuals that are interested, there he is, who'd like to develop a deeper relationship with cannabis and cultivate their own medicine. He'd be a good person to speak to this afternoon.
It's called Grow 6 Big Ones. We'll teach you how to grow 6 big ones.
Also like to thank Cella Fiorini for her efforts, and like to introduce Cella. Is Dan O'Brien here still? I don't know if Dan's still here. Dan, I want to thank Dan is the prime nurse over at Primrose, and they do remarkable work. And Dan, I'd love you and Cella to hook up at some point, because I think there'd be good connection there. So this was a picture that a kind stranger took of me and my dog Rainbow a few weeks ago over at Goat Rock on the coast, and I love the sunset, and I look at life and getting old in life a little bit like that sunset. And what I try to do is help people enjoy the sunset more, and I think cannabis can play a role in that. I was looking through some journals before this talk, and I just want to show, I don't know if people can see this, but it's a recent edition of Psychiatric Times, which goes to about every psychiatrist's office. And the title is 21st Century Reefer Madness. And what's interesting is that they basically repudiate a recent book called Tell Your Children that a journalist wrote, all about the evils of cannabis, saying that we as psychiatrists need to investigate the therapeutic uses more. Underneath that is an article entitled Cannabidiol as an Adjunctive Treatment for Schizophrenia, which is quite remarkable because my education up to date suggested that cannabis was a potential trigger for schizophrenia, and it may still be in some vulnerable individuals, but it's interesting that it's now found to be quite efficacious to treat positive psychotic symptoms in schizophrenia. Whoops. So I'd like to start this talk. I'd like to divide it up in some segments. First, it's not every day that you get to hear a psychiatrist speak, so I'd like to just run through the mental status exam, which is the psychiatric equivalent of a physical examination. It's what I do when I meet with people. And then I'd like to discuss just some thoughts I have about the role Schedule I substances may have in healing, and then specifically talk a little bit about cannabis. I'm going to save some time afterwards for any questions that individuals have, so hopefully we'll provoke some interest. So the mental status exam is a psychological equivalent of a physical exam that describes the mental state and behavior being seen. It includes both objective observation as well as the individual's subjective description of what's going on. That's often the case, except in conditions of, say, advanced dementia, where it's purely observational because the person can't tell you what's going on. So in a mental status exam, it provides information for diagnosis and assessment of the disorder and a response to treatment. It's a tincture in time, and it can help other clinicians get an idea of disease progression or change over time of an individual. There are several components to a mental status examination: appearance and behavior, motor activity, speech, mood, affect, thought process and content, perceptual disturbances, cognition, abstraction, insight, and judgment, and I'm going to run through those. We start off with appearance and behavior. To me, a picture is worth 1,000 words. Just seeing the individual walk into the room, the examination begins. We see people that are slowed down, psychomotor retarded, psychomotor agitated, with tremors, maybe disheveled, unkempt, drooling. So we like to observe what's going on. We look to see if they're psychomotor agitated or retarded. We particularly see psychomotor retardation and stiffness in Parkinson's disease. We look at their speech, or we should say we listen to their speech, their rate, their volume, and their rhythm. If they're depressed, they're very monotonal. If they're manic, they may be quite fluid. If they're agitated, they may be quite loud. And we look for fluency in disorders of speech. We inquire what the individual's mood is. How are they feeling? How are they feeling in that moment? How are they feeling in general? This is the subjective description of an experience. Then we evaluate their affect. How do they appear to us? Are they restricted in their affect? Or are they quite labile all over the place? Is their mood in the middle? Are they depressed? Are they expansive and euphoric? Are they anxious? We look at their thought process. Do they make sense to us? Are they coherent? Or can we not understand what they're saying? In my experience, I find many individuals who are just without a psychiatric condition, but maybe tangential, where you are here and you end up over there. There's a stream of association, but they just don't make sense. Other individuals are circumstantial. They may scurry around the edges without addressing what's being inquired. Many individuals are thought disordered, where they may have loose associations or flight of ideas. We see derailment and loose associations in individuals with schizophrenia, and those are individuals that absolutely make no sense. We often also see individuals that we can't understand who have aphasias. Aphasia is an injury to the language area of the brain. There's expressive aphasia, where they know what they want to say, but what comes out doesn't make sense, and that's very, very frustrating and often results in depression. Then there's a receptive aphasia, where they don't understand what's being inquired, and oftentimes there's mixed aphasia. And then you often see thought blocking, and you often see that in individuals who are anxious or depressed. With regard to thought content, we pay attention to whether an individual has delusional mentation. What is a delusion? A delusion is a fixed false belief. In dementia, we often see persecutory delusions, delusions that are paranoid in nature, delusions of infidelity, and we often see in mental health other types of delusions. For instance, in a manic state, we may see somebody who has a grandiose delusion. And we always inquire with regard to suicidal or homicidal thinking. With regard to perceptions, we evaluate whether the individual is experiencing illusions, that is, misinterpreting what they're seeing, or hallucinations. A common type of hallucination that we encounter are auditory hallucinations. But there are other types of hallucinations. For instance, we sometimes see visual hallucinations. There's a fascinating condition called Charles-Bonnet syndrome, which occurs in individuals with impaired vision or an injury somewhere along their visual tract, where they don't have a mental illness, but they will hallucinate formed images. Often they're Lilliputian. For instance, a circus of little people or animals at the corner of their bed. And it's my job to convince them they're not losing their mind is just playing tricks on them. And unfortunately, there's no treatment for this. Sometimes you can see tactile hallucinations. For instance, in types of alcohol withdrawal, you have sensation of insects crawling on you called formication. And in some types of seizures, you may see olfactory hallucinations. And then in the older population, it's always important to assess cognition. And cognition entails several domains: their alertness, their orientation, concentration, their memory and font of knowledge, their ability to think abstractly. And we use various measures. In my training, was trained to utilize what's called the mini mental status exam, which was developed at Hopkins by Marshall Folstein. But since then, there are more refined measures, such as the MOCA, the Montreal Assessment, or the St. Louis University Mental Status, or the SLUMS. And we can sometimes get a sense of what the nature is of the disorder just based on their cognition. For instance, in the mini mental status exam, we find that in Alzheimer's dementia, orientation is often lost before concentration, whereas in vascular dementia, it's reverse. So with regard to dementia, what are some of the behaviors that we see, and why do people come to me? If it was just a uncomplicated dementia, they usually don't come to see a psychiatrist. But oftentimes people have what are called complicated dementias, and that could be a dementia with depression, or rarely mania, dementia with psychoses, and most commonly dementia with behavioral disturbance. And these are examples, and this is from Dilip Gestia, psychiatrist from University of California, San Diego, who analyzed the data and showed that the most common type was aggression and agitation, followed by apathy, delusions, anxiety, psychomotor disturbance, particularly agitation, hallucinations, aggression, irritability and lability, sleep-wake disturbance, depression, disinhibition, sundowning, hypersexuality, and OCD. The conditions that I've found over the years that cannabis has been most helpful for include the agitation, anxiety, aggression, and the sleep-wake disturbance. How have we approached this traditionally in psychiatry and in medicine in general to try to help people with these conditions? Well, we've utilized different classes of medications. The first are the antipsychotics, and Dr. Hergenrather discussed some of these, but I'll elaborate on that. These include medications like Seroquel, olanzapine, which Mr. Beale's wife was treated with and still is at a lower dose, Risperdal, Haldol, and all these drugs have black box warnings, may increase risk of sudden death if used in individuals who have dementia. And Dr. Hergenrather mentioned that sleeping medications and some antidepressants also have black box warnings as well. They also have many untoward side effects, everything from what's called extrapyramidal symptoms, which may entail Parkinsonian-like symptoms such as stiffness or tremors, restlessness, akathisia, and some of the newer antipsychotics cause what's called metabolic syndrome, which can include weight gain, diabetes, hypercholesteremia. We also use certain mood stabilizers, particularly the anti-epileptic drug Depakote. These can be hepatotoxic and require routine laboratory monitoring. Benzodiazepines such as Ativan, Xanax, the longer-acting Klonopin, which we try not to use any of the benzodiazepines. And interestingly enough, they now find that chronic use of benzodiazepines is associated with increased risk of developing dementia. And lastly, the antidepressants, which can have side effects such as apathy, gastrointestinal symptoms, diminished sodium, sexual side effects, and others. Of these, some we definitely want to avoid, such as Paxil, because Paxil is very anticholinergic compared to other antidepressants. And when we see medications that may be anticholinergic, that is lower acetylcholine, we try to avoid them because individuals who have or are developing a dementia already have diminished acetylcholine. And there are actually apps now that can give you the anticholinergic load of medications because, as you know, older individuals are often have what's called polypharmacy, where the medications themselves may not be individually anticholinergic, but the cumulative effect is anticholinergic. which can cause many untoward side effects. So we try to lower the number of medications as much as possible. Lastly, we have the dementia medications, which I'm not terribly impressed by. I let people know that they're available, but many people don't want to take medications. Those people, I don't push them on other people, want whatever's available that's out there. And these include the cholinesterase inhibitors. Most commonly used is Aricept, and then there's also Exelon and Galantamine, and Namenda, which lowers excitatory neurotransmitter glutamate. So I put this slide up because cannabis is Schedule I. It's used by many individuals to get high, as are other substances. But we're not the only species that likes to get high. Jaguars chew on Banisteriopsis caapi, which contains dimethyltryptamine, and it's one of the plants used in the psychedelic ayahuasca. Dolphins they postulate get high by sucking on pufferfish. And then there are other, in fact, there's an ethologist from Italy that's written a book on animals who get high. So question is, why do we get high? I think we can more comfortable speculating why humans get high. It's hard to say why animals might ingest substances that may alter their consciousness. This is a recent article that came out of proceedings of the National Academy of Science, where they found recently in Bolivia traces of 5 drugs in a sack, and in here were the ingredients in ayahuasca, dimethyltryptamine and harmines, cocaine, the psychoactive ingredient found on the skin of certain toads, other substances, as well as ceremonial items, and they suspect it may have been from a shaman. But we've known for 6,000 or more years that cannabis has been used by humans. And in fact, the Emperor of China, about 4,700 years ago, wrote the first medical compendium on the uses of cannabis, but he also talked about the spiritual uses of cannabis. And in the Odyssey by Homer, which was written about perhaps 2,500 or so years ago, there's a mention where Odysseus is coming back from war, exhausted, fatigued, and distressed, and Helen of Troy invites him over and his colleagues to dinner and serves him a concoction of wine and an herb. And I was listening to a talk by Gábor Maté, a brilliant Hungarian physician who works in British Columbia. And he speculates that he wouldn't be surprised if that herb was hemp, because we knew at the time it was a herb from Egypt, and hemp was readily available in Egypt. So when people come up to me and thank me for pioneering work that I do, I remind them that I'm not reinventing the wheel. And it's interesting how I got involved in working with cannabis with individuals. My first patient was a woman with advanced dementia who was so agitated she was keeping everybody up at night at the residence. So I tried every class that I just showed in the book: antipsychotics, mood stabilizers, dementia medications, benzodiazepines, you name it. And she either didn't respond or couldn't tolerate it. So I put my hands up and I said to her durable power of attorney for healthcare, I said, well, why don't we consider cannabis? And there was much hemming and hawing, but finally she agreed, and voila, she was fine. And I never had to see her since because she was stabilized on cannabis. So this is a study that was done by Matthew Johnson and his colleagues at Johns Hopkins, showing the therapeutic uses of psilocybin to treat tobacco addiction. And I just want to segue a little bit about psilocybin and other Schedule I substances because there's a wellspring of research that's going on now, funded by organizations like maps.org or the Hefter Society. And it's quite impressive that this research is being done because the medical establishment funding is largely driven by the pharmaceutical industry. But they do not have a vested interest in re-examining the potential therapeutic uses of these substances. So we know now that psilocybin may be efficacious in treating depression. There was a paper out of the University of New Mexico where it was helpful in treating severe obsessive-compulsive disorder. And my brother has actually done some pioneering work in utilizing psilocybin in people with terminal cancer and coming to terms with the inevitable end that was nearby. And that research has since, he's at University of California, Irvine, and that, at Harbor Hospital, UCLA Harbor, and that research has actually been replicated at New York University and Johns Hopkins. We also know that MDMA, otherwise known as ecstasy, can be very helpful in treating PTSD in a therapeutic context. That's MDMA-assisted psychotherapy. And there's much research that's being done now on the therapeutic value of cannabis for PTSD. And it's no irony that when Colorado legalized cannabis, the first state to do so, the first individual to purchase cannabis was an Iraqi war veteran who was suffering from PTSD. There's also research that's being done showing the potential therapeutic value of ayahuasca and ibogaine, potent hallucinogenics in treating addictions. And in fact, what many of you probably don't know is that Bill W., the founder of Alcoholics Anonymous, attributed his ability to get off of alcohol in part to his experience in a therapeutic context of using LSD. That was never implemented in the AA model. So where are we today? Well, this just from the other week. Denver voters approved measure to decriminalize psychedelic mushrooms. And in fact, Portugal, for several years now, has decriminalized substance use to the best of my knowledge. And what's interesting is that they've taken the money used for the war on drugs and have given it over to healthcare and education. And are they seeing increased substance abuse, morbidity, and mortality? To date, I believe the answer is no. It's interesting to see what will evolve in the United States. But I think there's we shouldn't move too fast. Let's not forget the 60s and the days of Timothy Leary. It just takes a few bad outcomes and a few bad apples to reverse the tide. So this was an op-ed piece in the New York Times by the author and journalist Michael Pollan, who just wrote a very interesting book called How to Change Your Mind, which is his journey into exploring psychedelics. And I encourage individuals who are interested in this to read his book. But he's encouraging us to slow down and be more judicious in the decriminalization of Schedule I substances and to promote more therapeutic uses. So, we live in wine country, and we even believe that alcohol may have some neuroprotective effects, but the latest literature suggests otherwise. So really it's time to revisit the curious fact that certain substances such as nicotine and alcohol are readily advertised and legal, and others such as cannabis are still Schedule I by the federal government. And this research shows that there was clear evidence of hippocampal atrophy, and I suspect as time goes on that will be the consensus, that alcohol is neurotoxic, whereas cannabis is neuroprotective. So, just alluded upon the use of cannabis as a medicine, and it's been used for thousands of years. We know that it helps with inflammation, it helps with seizures, it helps with mood. The English physician William O'Shaughnessy in the 1800s wrote a paper on the therapeutic effects of cannabis as an analgesic, a muscle relaxant, an appetite stimulant, and perhaps even an anticonvulsant. In fact, Queen Victoria in the 1800s was prescribed cannabis for cramping. In 1995, The Lancet came out stating that the use of cannabis, even in long term, is not harmful to health. With that said, if we look at the history of cannabis in the United States, we see that in the 20s and 30s, the first drug czar or drug hound, who had ulterior motives of power and funding, created a war on cannabis. And it's interesting that the majority of users in the United States at that time were blacks and Latinos. So there was a racial element to this war. The rest is history. Soon after, there was reefer madness and the whole belief that cannabis is a gateway drug to addiction and causes psychosis and violence and mental illness and has absolutely no medicinal uses. Well, the thought that it's a gateway to addiction, it's no more a gateway to addiction than soda or a candy bar, because people who abuse substances often enjoy soda or candy before more powerful substances. And as I mentioned, one of the impediments to bringing cannabis into mainstream medical use is lack of funding. But this just out, a benefactor just gifted Harvard and MIT $9 million to study the therapeutic uses of cannabis. And actually there's a plant-based cannabis product now called Sativex, which is marketed and being explored. And there's a conflict now in the federal government between the FDA, which is seeing therapeutic potential of cannabis, and the DEA. So we know that cannabis can help, as Dr. Hergenrader mentioned. I won't repeat him, but there's no doubt that it can diminish the use of opioids. And it's quite sad. I had a woman come to my office, a patient of mine who I see once a year to give a cannabis recommendation, who told me that the pain specialist that she sees for her opioids told her the other day that he would no longer prescribe her opiates if she continued to use cannabis. So there's still much need for education. And in here it also says decreases anxiety with agitated patients. It can decrease agitation, anxiety, psychomotor activation, sleeplessness or sleep disturbance, mood instability, and appetite problems. Cannabis is not a panacea, and as you learned today, we need to be respectful of its potential potency. Oftentimes I see it overdone with edibles because people will take some, they don't notice anything, and they'll take some more. But as Dr. Hergenrather pointed out in his slide, there's a delayed onset of action, and before you know it, they're floored. So the most common side effects that I'll see, psychiatric side effects, are paranoia and anxiety. And for individuals who are trepidatious, start with very low doses and start with predominantly cannabidiol over THC. So this is a recent study out of the Dent Neurologic Institute in Buffalo, New York. It was a retrospective study, and I have let me show this slide. Describes the study as 204 patients enrolled in the New York State Medical Marijuana Program. New York allows, in a very restricted way, the medicinal use of cannabis. It's not decriminalized. The average age of the individuals were 81. There were various ratios of CBD to THC over a 4-month period. Almost 70% experienced some symptom relief. 21% with side effects, the most common being sleepiness, gait disturbance, and gastrointestinal symptoms. 3%, only 3% had to discontinue because of side effects. And interestingly enough, but not surprisingly, there was a decrease in opioid use of 32% of individuals. This study from April of this year in medical cannabis and cannabinoids was a very small pilot study in a nursing home in Geneva. And they utilized a 2-to-1 CBD to THC extract, and dividing in 3 doses approximately 20 milligrams of CBD and 10 milligrams of THC. And they infused the oil in cake to make it more palatable. In 2 months into treatment, half of the seniors eliminated or significantly decreased the use of prescription medications, including morphine, benzodiazepines, and antipsychotics. And they found a significant diminution in behavioral problems and rigidity. This question was already addressed, but I'll just reiterate that I am often make visits to residential care facilities and skilled nursing homes, and it's been quite frustrating at the skilled nursing facilities because of their relationship with the federal government. They may be in principle receptive to the efforts of introducing cannabis to alleviate suffering, but their hands are tied. I just know of one sniff, which I will not mention, that I had a patient who was already on cannabis, who had dementia and agitation, and who was admitted there. And they were kind enough to look the other way and allow it in. But to initiate cannabis at these facilities, it hasn't happened yet. Hopefully with this prop, I believe it was 305, we may be seeing a shift in the current. So just to reiterate that cannabis clearly has medicinal therapeutic uses. Most individuals utilize cannabis recreationally or unbeknownst to them. They are self-medicating, pain, anxiety, sleep disturbances. There's probably a small subset in the population that have a psychological addiction to cannabis. But we can have psychological addictions to many substances or non-substances. We can have addiction to shopping, to gambling, to sex. So this really reflects, it's more of an issue of the problem of the human condition, and calls in the need for more psychotherapy. But the risk of cannabis, in my opinion, is quite low, and it can have a significant therapeutic value, both in the population of individuals who have dementias, who may not volitionally be taking it, but also across the lifespan, whether it's children with epilepsy or autistic spectrum disorders with agitation, to adults with a variety of pain conditions or trauma and anxiety, to older individuals who suffer from pain, sleep disturbance, and the angst of growing older. So I thank you for your attention, and I'd be happy to answer any questions you might have.
Awesome. Thank you. So does anybody have a question that they'd like to open the floor with? Go right ahead.
Is cannabis an appropriate substitute for traditional bipolar medication?
The question is, does cannabis have...
Does cannabis have a therapeutic value in treating bipolar condition? And so far, the studies show no statistically significant benefit of utilizing cannabis. That's not to say in individual cases it may not be beneficial, but there are also case reports of it provoking mood instability and grandiosity. So we can't justify its use as a recommendation, although I'm always receptive to learning of individual stories to glean clarification whether it may play a role in its therapeutic use.
Okay, I recently saw a movie.
Could you speak up, please?
I recently saw a film that was produced by someone about mushrooms, and they have proof that, or they're developing further proof. They have proof that lion's mane actually reactivates or reforms neurotransmitters in the brain. Has this been used in dementia, do you know? Because you mentioned mushrooms here.
I think that information is quite new. I haven't seen anything in the literature yet. That's not to say that research is not going on. There are researchers all over the world investigating how to impede the development of dementia. There's a brilliant mycologist, Paul Stamets, who I would encourage people to check out if they want to learn more about the benefits of mycelium and mushrooms.
I wanted to ask a question on behalf of the Homestead attendees and the caregivers that we have here and the hospice caregivers. How do we know when to call you? And I don't mean you, I mean euphorically you. Yeah. How do we know?
Oh, you don't know. We in this room will either develop dementia or will care for a loved one that has dementia. That's just the reality. And if the situation is untenable, unmanageable, and you as a caregiver are distressed and depressed, I'd say you've waited too long. Don't wait that long. Ask for help. There are 3 geriatric psychiatrists I know of in Sonoma County. One of them is at Kaiser. Unfortunately, to the best of my knowledge, Kaiser has not opened its doors yet to cannabis, but probably will when the federal government gives its okay. I'd say that if you have any concerns or questions, you can feel free to call me or email me, and I'll try to address them.
Anything? Yes, in the back?
Okay. You had an excellent slide about side effects of cannabis. How do you detect the difference in effectiveness of the cannabis if you're treating someone with dementia who has the same symptoms as your slide?
I see.
Between the symptoms.
Right. Well, that's where the mental status exam comes into play. When I first see them, the likelihood that they're on cannabis is quite low. So I evaluate, do they have any of these symptoms? Do they have psychoses? Do they have anxiety? Do they have other symptoms that you saw or alluding to on that slide? And then I gradually introduce cannabis. Dr. Hergenrather mentioned 10 milligrams. I'm a little more conservative. I maybe start a 5 milligram mix of CBD and THC and just go from there. And again, it's a personalized response. Everybody's different. Some people you lower the dose, some you keep the same, some you raise the dose. Thank you.
Yes.
I'm just wondering if you could speak to the potential that cannabis can be used as a preventative medication for Alzheimer's.
Oh, good.
Well, that's a good question, and it would be a wonderful epidemiologic study to take a segment of the population that are chronic cannabis users, comparing it to a control group of non-users, and following them over time to see what % go on to develop dementia. As Dr. Hergenrather mentioned, we've known for some time, since a study done at Scripps Institute in La Jolla, California, that cannabis is more efficacious in preventing or decreasing deposition of plaques and tangles than the FDA-approved medications for dementia. So that's a given, that's a known. But by the time I enter into the picture, the cognitive decline is fairly advanced. So I am asked to address symptoms that are a result of the dementia as opposed to treating the dementia itself.
In the back?
Phil, I would just add that when it comes to titrating the dose of cannabis, raising it or lowering it, cost often comes into a significant consideration. These medications are not covered by insurance. People have to pay out of pocket for them. And doubling from 5.5 to 10.10 is pretty much doubling the money you're spending, which is multiple hundreds of dollars.
Yeah, that's right, Dan. I've had many family members that have come to me and said, you know, I'd love to work with cannabis, but I just can't afford it. Yeah.
Yes.
Did you know that there's a group that actually gives away free samples of cannabis?
Well, Paul Ennis is one of them he mentioned. I don't know if that's who you're referring to? Yeah. So thank you, Paul, for your good work.
There are a lot of grassroots efforts. I know it's going to come through research, education, and voting, obviously, which is the clear case. Did you have one more question back here?
So I'm hearing that the cannabis is not covered by prescriptions, but what about Marinol, which has been with the...
Right, good question. I'm often asked that. What about Marinol? And I have no data, no studies. All I can speak to is my own personal experience, is that I'm not a big fan of Marinol, which is a synthetic THC. It just snows people. It does not improve their quality of life, in my experience. I much prefer working with the plant itself.
In the way, way back, nice and loud, because it'll take me that long to get back there.
Okay. Hi, can you hear me? Yes. Okay, so if patients can develop tolerance to cannabis, does this mean that the dose continuously needs to increase as they continue to use the cannabis? And then in addition, does the body begin to naturally decrease its own production of cannabinoids as external ingestion or use is given?
Right, those are very, very good questions. The first is regard to tolerance, known in the medical literature as tachyphylaxis. That does occur, but I rarely see the need to push the dose. And Dan maybe can give me his experience, but usually if we find a dose that works, I don't get called back. And I'm sorry, what was the second?
Second half of your question?
So the other is if you're introducing external cannabinoids into your system, does your body start to not produce its own production?
Before I answer that, I want to ask Dan. Dan, is your experience that the dose needs to be pushed routinely, or?
In my population who are elderly and vulnerable, it's far more common to be reducing the amount of medication they get over time because the medication is having a stronger and stronger effect on them. Probably because of the effects of aging in this field.
I don't know, but that's true. I think, as Dr. Hergenrather said, you may overdo it at first, but give it some time, and there'll be a modification and reaching a calming point. And then, as the calming persists, there's an effort made to lower the dose, and we often don't have to increase it. But there's no doubt that it has significantly reduced the need for prescription allopathic medications. It doesn't remove all the time or the use, but it lowers the yield. And then with regard, I don't know any studies I wish Jeff were here. He'd be better to ask that question, but it's an interesting one, which is, does exogenous cannabinoids reduce the endocannabinoids that we have in our body? And I just don't know that. But what's interesting is, Gabor Mate talks about abuse and how the powerful influence of the endocannabinoid system on homeostasis, and this goes hand in hand with the human developing brain and nervous system. And a study at a Journal of Pediatrics in 2012 out of Harvard showed that the most important factor in the developing human brain is the bond between the infant and the adult. So it's no surprise that individuals who are prone to abusing substances have trauma in their childhood. As Gabor Mate would say, all you have to do is scratch the surface to find trauma.
If there's no, oh, yes, one more.
Well, given that it's a plant, I don't know. I mean, I'd love to see that in my lifetime, but who knows what's going to happen with our insurance system now that there's a movement towards universal health care, right? So let's see how that plays out, and then I might be better able to speculate, but I honestly don't know.
I think we have time for a couple more. Yeah.
Do you consider cannabis holistic?
Well, I'm not an expert on holistic medicine, but it is it's not synthetic. It's not manufactured by the pharmaceutical industry. It's a plant. So with that said, if you were to corner me and say yes or no, I'd say most definitely yes.
Okay, we'll take one more. We'll take two more, and then we will stop.
This is just a plug. We all got this in our bags today. I bought 50 copies of this and given it away as part of our meetings every week. In this edition of O'Shaughnessy's is all of the science. Dr. Hergenrather's talk is in here in detail. If you like science and want to understand what's going on at the molecular level, it's right here. I urge you all. The questions that have been coming are great, but all the info, honest to God, is right in this issue.
You're very welcome. We're hopeful that all of the information that's in the bag from everybody is going to add to this knowledge basis. One last question from our president of the Society of Cannabis Clinicians, which is not an easy thing to say.
Well, thank you. And we do publish the O'Shaughnessy's, which is in your bag, and we have a lot of educational materials on our website, including videos from researchers from around the world who are doing studies, clinical-based studies that cannot be done here because of the federal restrictions. I wanted to talk about some aspects of tolerance, and the tolerance is mainly to the psychoactive effects of THC. So people who take recreational cannabis find that they need more and more doses, higher and higher doses, and resort to things like dabbing and other kinds of things to get a higher concentration of the THC to get the psychoactive effect. That's a kind of tolerance that may be unrelated to the medicinal benefits of THC and the other cannabinoids. So the higher and higher psychoactivity and that tolerance may not at all blunt the effect, the analgesic effect or the soporific effect of cannabis. We know that when people expose themselves to higher and higher doses of THC, the receptor population on the nervous system tends to decrease. So you're kind of beating those nerve receptors, and the body has a way of protecting itself by retreating, pulling those receptors inside the cell so they're no longer available, which is why you need higher and higher doses. But we found that if you take a drug holiday, if you stop using the cannabis 2 to 3 days, or if you switch the strain, the effectiveness has been restored.
So yes, Dr. Robinson is here from Alameda. Yes, he is the president of this society, and he's also a wealth of knowledge, he and Dr. Hergenrather and Dr. Grob. We are going to take a 10-minute break. There are Girl Scout cookies in the back. Thank you, Dr. Grob.
Thank you.